There you go. Sorry.
Hi everyone, I'm Robin Nabi from the Leapfrog Group.
April?
Hi, I'm April Jagalo. I am from the University of New Mexico, and I had the great honor and pleasure of working with Marty and Armando, starting our PFAC program for our organization.
Marcy?
Marcy Romero, and I'm the manager for the Patient Family Advisory Committee at the University of New Mexico Hospital. And along with April, I also worked with dear friends, Marty and Armando, and they are fantastic.
Kathy?
Hi, Kathy McGowan with the Georgia Hospital Association. And I've worked with Armando for years and Marty, and you guys are the best. And it's very nice to meet Michelle and Erica. I'm from North Fulton, Wellstar. So I did not know you before, so thank you. I've got your name now. Uh-oh.
And it's
Yeah.
Evelyn, is Evelyn, right?
Yes, Evelyn.
Yeah,
Hi,
Evelyn.
I'm Evelyn Jones from St. Bernard Hospital, and we also work with Marty to establish our PFAC.
Monda?
Oh, sorry. I thought you said Mondo.
No, I said Monda.
Who's that? Hi, everybody. I'm Vonda Vaden-Bates. I come to the patient safety because of the loss of my husband in 2012. I work very closely with both Marty and sometimes Armando as well. I'm a board member of Patient Safety Movement Foundation and the CEO of 10th Dot.
Michelle?
Hey everyone, I'm Michelle Chow. As Kathy had mentioned, I work with Erica at Wellstar North Fulton. I started a new role as an operations manager, and I am involved in our Patient Family Advisory Council.
Erica?
All right, so my name is Erica Steed. I'm the Director of Patient Experience at Wellstar North Fulton. I previously worked at AU, or the Medical College of Georgia, for 16 years. I worked under the leadership of Pat Sadomka and Bernard Roberson. You guys may know them. Pat passed away many years ago. First, I was a patient advisor for my son Ellison, who's autistic. So that's how I got into this arena. Believe it or not, my background is actually computer science. I love this arena so much, they pulled me over to become a patient advocate, and I've never looked back since. And I know Marty in a different capacity. And then actually the other day when I was on a call with Armando, my now CMO, Dr. G, says, I know Armando, he helped us to start the PFAC program here at North Fulton. So I've been here for 4.5 years. Evelyn Gow has been leading the efforts for our PFAC. And they're asking me to come in with, my expertise from AU Health with Pat Sadomka to, strategize and just build a program, take it to the next level. So I'm really excited about being on this call, seeing what you guys have to offer and how we can just take the PFAC to the next level.
Great, thank you. Marty? I think everybody knows you, Marty, here, but maybe for Michelle, she doesn't know you.
Armando, we have a great group. Can you hear me?
Yeah, I can hear you. I was calling on you to maybe just give a brief introduction to yourself, just for Michelle, because everybody else knows you here.
I will, thanks. And I'm wearing a mask because I'm in the middle of I'm in the lobby of an office building, a medical office building, about to have a root canal. So as soon as this phone call is over. So I apologize for that, for my muffled voice. And also I've got a very unstable connection, so I'm gonna be in and out. But with that said, I'm Marty Hatlie. I have worked with Armando for years to build patient family advisory councils that are very focused on quality and safety in a number of hospitals. And we, in response to the times, have put a lot of our training and tools and resources.
He's got a back connection, so.
I've got a bad connection.
Yeah.
Back, but we reached out to people that we knew and who knew us to show you a preview of the product that we put together to help hospitals build PFACs that are very focused on quality and safety.
Yep.
And Armando, suspect I'm going to be in and out of this entire webinar, so I'll
That's
do my
fine.
best to keep up with it.
I'll back you up. So let's share my screen so you get to see what we're talking about. And
Armando, I'm sorry, I forgot to mention this. So at Wellstar, we're 11 hospital system, and we are the most mature PFAC peer, but I'm here listening, tuning in today to see how we may be able to pollinate and spread this program to all 11 hospitals. So I just wanted to share that.
yeah, so there's a couple of things before we give you an introduction and you'll see it later on, Erica, is that we have built all of our assets into this platform we're about to show you. And then, so that's pretty much for people that want to start a PFAC. But then we have a whole other program, which we call PFAC 2.0, is to take existing PFAC to the next level. So without further ado, I'm just gonna share my screen, and we'll give you a quick history how we came about. And well, let's see. All right, can you see the presentation?
Yep.
Great, okay.
Yep.
All right, so again, thank you for joining Marty and I today and allowing us to demonstrate this virtual learning approach to timely and cost-effective implementation. So, you know, who are we? We are H2Pi. For those of you that don't know, the Healthcare and Patient Partnership Institute. Brief history here, how we came about. Back in 2011, when CMS, the Centers for Medicare and Medicaid Services, introduced the Partnership for Patients, my wife Victoria and I felt compelled to help hospital embrace the patient's voice. And we developed a guide from the patient perspective on the how-to. And that ended up actually going all the way to the Georgia Hospital Association. We go way back, and they recommended that we did 6 of them, one for patients, one for the C-suite, and one for the nurses, one for the docs, and so on and so forth. And at that point, we reached out to a gentleman you see here, Martin Hadley, who was a veteran in this kind of work, not by his age, but by his expertise. And he obviously was all in because that's his passion. And then we felt that we needed a little bit more of a backbone by having, you know, who knows Armando and Victoria, right? So we thought, well, let's see if we can bring a doctor with us to just help us kind of launch, you know, this whole effort. So we reached out to Dr. Tim Mcdonald, you see here on the bottom right, and right from the get-go, he was, you know, he never hesitated for a moment to join in. So, so today we're pleased to say that this past year, during the pandemic, during the winter, Marty and I worked diligently in partnership with Vizient Southern State. So Activate and Raleigh. So who are these people? Vizient Inc. Decided a while back to sort of section off their membership hospitals into regions. And so southern regions, the southern states, I think it's about 5 states, the reaches all the way out to Louisiana. They contacted us and say, hey, you guys still doing PFACs? Yes, we like to talk to you about this new idea that we have about, you know, virtual learning. And Activate is the company under Vizient Southern States that actually does all the management, the back-end work of this platform. Raleigh is the artificial intelligence software that drives this entire e-learning that we're about to show you. So what brings us here? Marty, do you want to tell us what brings us here today?
I'd be happy to, Armando.
Can you see the slides?
Yes.
Marty may be going in and
Okay,
out.
I'm back. I'm back,
Okay.
but I don't see your screen, Armando.
You don't see the slides?
I don't see the slide, so I'll just talk through it a little bit.
Okay,
Give people a little bit of background. I see.
we have the slide
Okay, I see
of
the busy.
the HRO and the journey.
Okay, it's interesting. I'm seeing old slides. So I'm seeing the Vizient and Activate one. Okay, so Armando, as Armando mentioned, we kind of came together thinking we were going to offer a lot of services to the CMS Partnership for Patients. And we did, but our first big client, honestly, was MedStar Health, that was on a high reliability organization journey and wanted to build patient and family engagement into it as a component of their pursuit of zero harm. And I have to give credit to Dave Mayer, the CEO or the VP of Safety and Quality there, for his vision here. He thought that patient and family engagement was a crucial part of improvement. There were a lot of PFACs around at the time, but many of them were not focused on quality and safety. And I would say, a good number of them were almost avoiding the issue because of the liability concerns around it, or just the reputation concerns of sharing your challenging data with your users of care. So this felt very visionary to us and a great opportunity. And we developed a process that we rolled out through all 10 of their hospitals to build PFACs that reported to leadership, and that included not only patients and family members, but staff people, because every hospital we went to, we saw staff people that were completely committed to safety and quality. They often had been patients there themselves or had loved ones there, and sometimes just didn't have a forum in the hospital, depending on what their job was, to talk about things that they had experienced or had seen. So we didn't really plan this for people whose jobs were safety and quality. We planned it for anybody in the hospital community that wanted to work with patients and families to move the needle forward. And what we found is the conversation was much richer when you had frontline providers, or even not frontline, even coders or observers or custodial people who were passionate about the mission of their organization, working side by side with patients. So that's kind of our first history, and we learned a lot through that process. One of the innovations that we learned there was the importance of having a direct line from your PFAC to your leadership and governance structure. So you'll see as we go through our staff that has just become one of our indicia of success. If you don't have that kind of connectivity to the top of your organization, you often find yourselves kind of marginalized or siloed.
Marty, you still on? Frozen. Everybody else can hear me, right?
Right.
Okay. Well, I think he's just fell off the grid here. So I'll just continue for him. About 2.5 years ago, oh, is he back? No. About 2.5 years ago, Vizient invited us to participate in a study that was funded by CMS. The question was, is there any correlation between patient and family engagement and improvement outcomes? And no one had done that kind of study before. So we embarked on this journey by, we interviewed about 100 hospitals. That was done through an assessment tool over the phone. Out of those hospitals, we came down to 11 hospitals that we were actually doing boots on the ground, so to speak. We had to travel and interview just about everybody, from leadership all the way down to various services in the hospitals, and do rounds with them as well. So the two important things that came out of that study were that there is a correlation between patient-family engagement and improving outcomes, specifically on patient falls and 30-day readmissions. There was also some correlation with infection prevention. Specifically, that came out of Emory Hospital. And but the two most important ones were patient falls and 30-day readmission. So one of our visit, you see there on the top right is actually Sanford Hospital, which when we were doing walking around the unit floor, they told us a story about that poster that you see over there, that the PFAC was asking, the PFAC member were asking, why don't they have their numbers up on the wall, hand hygiene compliance and infection prevention and all that. And the leadership went absolutely nuts and said, well, we can't do that because if we put our numbers up, patients will go across the street to the other hospital. And the PFAC pushed and pushed, and they got it through, and no one walked in across the street. Transparency is the key here. So the more transparent you are, the more people want you to be the best hospital it can be in their community. So on the bottom right, we were at Denver Airport, and through our interviews, we would come up with this method of putting post-it notes up to kind of decipher all of the findings from those interviews and those recordings and kind of make some logic to it so that we would build what CMS called a change package. On the left, the big picture on the left, the gentleman next to me is the chief nursing officer at one of the hospitals that we visited, Parish. It's the hospital in Florida that actually handles any incidents with our astronauts. It's a wonderful hospital. They won a lot of awards, but we were sitting in this conference room. Oh, there you are, Marty. We were sitting in this conference room, and kind of almost at the end of the day, I asked Edwin Lofton is his name. I asked him, why do you do what you do? And he turned around and he pointed to this whiteboard that was behind us. And Marty said to him, I said, do you realize that's one of those pictures is Armando's son? And he had heard my wife, Victoria, do a presentation years back with Vizient, but he didn't correlate my last name with my son's, name. So it was quite the moment. We all shed a few tears, and it was very special. So, Marty, do you want to say anything else on that?
Well, just, we were inspired by all the different hospitals, and there was a huge range, everything from rural hospitals to big academic medical centers. Geographically, we went everywhere from California to Maine to Florida to Bismarck, North Dakota. And we saw innovations every place. And this one was pictures of people who died in a preventable way that this hospital keeps in its executive conference room to remind them of mission every single day. And you could just feel the culture in that organization. There were signs about safety all over. They recruit their PFAC members from people who filed grievances. Edwin sits down with people and enlists their help when they bring a complaint. I mean, it was just one example, but a powerful one of the kinds of things that we learned and the innovations that we saw on the road.
Okay.
And I took that picture. I'm going to put that picture in my obituary because that picture was just so amazing to when Edwin realized who Armando was, and Armando realized that, Josh's the loss of Josh was being used to inspire. It was just one of those gooseflesh moments.
It was wonderful, yeah.
I have a better connection, I think, now. We're going to give it a shot. This is the logic model that came out of those 10 visits. This is sort of the architecture of the change package chart, which is just a fancy word for our toolkit. But I want to walk you through this because I think it was a breakthrough, at least in our thinking. And this is where we think patient and family engagement actually contributes to safety and quality. If you look at the circle in the upper left-hand corner, that's where a hospital puts together its strategy and its priorities and its strategic plan for the year, for the decade, about what they're going to do in quality and safety. The purple box is the operation they build out to achieve that. So it's it's sometimes in quality, it's sometimes in safety, it's sometimes in risk, but it's got a budget, it's got goals, it's got accountability structure, and it's got some kind of metrics. What we looked for were hospitals, and we did a survey of, this was through Vizient hospitals, of those that had robust patient and family engagement. And those are the gray boxes. And to evaluate robust patient and family engagement, we used the 5 metrics that were being used by the CMS HIN network. So do you have a patient on your board of directors? Do you have a PFAC? Do you do nurse shift changes or huddles at the bedside? Do you have a department or a person whose job is patient safety? And do you use some kind of a checklist process to be consistent with your admissions, with your discharge process? Those were the 5 things. And what we then looked for in the hospitals we visited and in the interviews that we did, because we did interviews before we identified the 10 hospitals that were high performers, we looked for, if you build that structure, how is it interacting with the purple box? How is it actually working with your safety and quality structure to add value? And then what we were looking for was the far right box, and that was if you bring your patient and family engagement work into your safety work, and this was almost always through the PFAC. Do you actually improve more than you would if you hadn't brought the patient and family engagement piece into it? And why I think this is revolutionary is because so long we in the PFE world, the patient and family engagement world, have been challenged to prove how a PFAC or another engagement strategy in itself makes an organization safer. And the practical truth is it doesn't work in and of itself. It's usually part of a bundle of things. It's a hospital where there's leadership that recognizes the value of PFAC and combines it with other parts of its operation to achieve results. So just in terms of the research going forward and how we're going to measure effectiveness, we've got to see PFE as part of a bundle and not an isolated factor, because it doesn't work in isolation. It works with everybody else in the hospital that's focused on safety and quality. And what we did see in this study was reduced falls with injury when you have a PFE that's a PFAC that's actively involved, and reduced readmissions. So there were concrete findings of outcomes that will add to a small but growing body of research about the effectiveness and the importance of PFACs as a safety and quality strategy. So that's the logic model. I think, I think highly of it. Let's go on, Armando. I think I want to run through this. So this is the change package that we produced out of this. You're not going to be able to read it, but we will send it to you. Many of you have seen it already, I think. But basically, there are 3 major drivers. The yellow box is leadership engagement, reporting relationship to leadership, having really acknowledged and celebrated by leadership and supported by leadership. The second is the kind of orientation that needs to happen with PFAC. This is the green box, with PFACS members and with the staff of hospitals on how to use the PFAC resource. So it's orientation, it's teaching them it's showing them your leapfrog group data, it's teaching them your method for quality improvement, whether you're using lean or PSA or whatever, PDSA. The blue is the innovation. This is where we saw hospitals that were fully engaged, really producing ideas in kind of a 2-way street. Hospitals would take their priorities to the PFAC and ask for ideas. PFACs themselves would come up with ideas that they were contributing back to the purple box, if you will. So that's the overview of this. And then the smaller rows that you see over to the right are really specific strategies or innovations that we saw in the hospitals we were fortunate enough to visit. We visited 10 hospitals and learned something new at every one of them. Armando, do you want to say anything about this before we move on?
No, let's move on.
Okay. Oh, so here is, on the right is the change package. We've got a document. I'm happy to send it to you if you'd like to see it. It's full of ideas, chock full of ideas and strategies that frankly someone's implemented so others could implement it. And then Armando on the left is an article that Armando and I wrote about our work at MedStar, because once we built that structure, MedStar's used it in a number of ways in their overall HRO journey, to be sure, but also in specific initiatives like a system-wide sepsis initiative, which you'll hear a little bit more about as we go forward. So we wrote that experience up, and it's a resource for those of you who may need to show, what we're talking about to others who read journals and trust journals and need to see things in journals before they really think there's evidence. Okay, next slide, Armando. Oh, this is, we have honored guests here today, April and Marcy, because this was our last gig before the pandemic. We had been retained by the University of New Mexico hospital system to build a patient family advisory council focused on quality and safety. We were supposed to start in March of 2020. And of course, the pandemic hit. And so we had to convert the entire operation to virtual. And what we found is that it worked surprisingly well. I mean, we were able to meet the deadlines that April and Marcy and team gave us, which were aggressive. They had their senior leadership wanted to get this done, yesterday. And we found that it was actually easier to schedule meetings. It was more cost effective because we weren't traveling. We had a lot to learn about using Zoom to do this entire installation process and training process and engagement process, but that worked well. And it was really that experience that brought us to where we are today, of kind of going, wow, if it worked that well at UNM, let's harvest the lessons learned there and turn it into something that others can use. And that's our product. And Armando, I think you're going to take the next slide, yes?
Yep. So we're going to show you how to building out a technology support solution for changing times. Before we
go there, maybe we should just take a breath, see if there's any questions so far, and also just thank April and Marcy for
they kind of left. So at least I don't see them here, but if
I'm here, Armando.
Oh, you are? But there you are. Okay.
Yep, we're here.
I have the full presentation on and I couldn't see you. So thank you. And we want to say a big thank you for our guest of honors here, Marcy and Romero and April Jagalo. So thank you so much for that. And really for allowing us to, Marty and I learned an awful lot, even though it was on Zoom, it was like a brand new experience for us because we had never done it. But now let's go into this, because this is the great technology that Marty and I want to show you. So what exactly is this? So this is a learning platform that is powered by Rally, as I mentioned earlier. It's the artificial intelligence in this particular software. It is a behavior-centered learning platform, which has artificial intelligence insight and is designed with community in mind. You do it as a group, right? The methodology behind it is based on three things: learn, do, and inspire. Now, most e-learning platforms that we know of, they tend to push content, while this platform from Rally engages and activates the team using that proprietary learn, do, and inspire. It combines all kinds of things. It combines videos, online and offline activities. It has community engagement, behavior-centered design, and artificial intelligence insight and administration at scale. So how about we go and check it out live?
Hey.
So let's go and check it out. And we're going to share a new screen. There it is. Can you see the new screen?
Yes.
All right. That's great. All right. So this is the platform. The color scheme that you see here, I want to mention this really briefly because I've had this question the other day. I said, well, does it have to be these colors? No, these are the colors of Vizient, Southern Region. So this is totally customizable. Once we get a client, let's just say like UNMH, then we would use the UNMH color scheme to build this out with the UNMH logo on the top left, which right now it says Activate. So that would change to the organization logo. This is obviously a demo. So it says demo right here, Patient Family Advisory Council for Quality and Safety. It has certain buttons at the bottom, which I'll go to it after we do this knowledge base demo here. The very first tile that you see, it's a learn tile. So what does it represent? It basically teaches you how to navigate this platform, this software. And it teaches you about the learn, the do, and the inspires methods that we use. So we obviously put it here so that people get familiar with this whole platform and learn how to navigate properly. So now for today's demo, we can jump from tile to tile. because we actually set up the demo that way. So we don't have a chance to go through all the tiles. But when it's live, when an organization takes this program, they have to do this whole journey sequentially. It has to be done in sequence, or you won't be able to move forward. You cannot skip. And you'll see what I'm talking about. For instance, the very first tile is a PFAC overview. So if I click over here, I go into, we have objectives for every single tile, and we have challenges. So you see that the first challenge right here is black with a check mark. And that's, I wanted to show you that I've completed that. So now I can just move forward. And so what we'll do now is we'll click continue, and it basically takes us to the next level, okay? Or the next portion of the journey of that tile. And in here, it asks you questions. We'd say to use the video on the right to learn about the benefits of a PFAC. Also, we give the benefits of a PFAC in a PDF, so if you can download that. And then we say, after watching the video, please answer the questions below and identify the different audience that are on board with your PFAC. And if the way it was built originally, we didn't realize this, is that I would click, let's say, legal and quality and communications. I would click submit, and it would say, oops, that's the wrong answer. So what we've done now, it's not on the demo, but it's on the live version. What we've done is that we put a hint now. So if you make a mistake, the first time, a hint pops up and actually guides you through the right answer. Okay. So let's go back to this. Marty, you want to show the leadership video?
Sure. There's 35 steps in this process. So we had the challenge for us was to really fit them into the learn, do, inspire categories. Learning is content we provide to our clients, our users. Doing are things that we supervise that they're doing. So we'll say, you need a charter, build a charter, or you need an application interview protocol, do that. And we get to kind of coach and review that. And then the inspire is you giving us back your experience and actually inspiring others that are using it too. So it's our feedback loop. That's why we liked it so much. It fit really well with what we're doing. What we're going to show you now is a video that's really a first step often is assessing whether your organization is ready to build a PFAC. And we wanted to give you a video, or users of this a video that they could use if their leadership wasn't ready. They could play it at a board meeting or at a C-suite meeting or some other leadership meeting, medical staff meeting, who knows. So Armando, we're going to play the first of our video assets. And we honestly went to our clients and said, tell us about your experience. So a lot of the assets here are things our clients was talking about what it was like to go through this process. I'm going to say a little prayer here, Armando, that we get to a place where video plays well, because we're actually watching the video through Zoom. It'll actually play a lot better.
When it's live, yeah. Okay.
Here we go. Let's show them our first video.
I cannot believe we think we could solve the quality and safety and value proposition without having our patients and family members around the table. And to those that say, well, I'm a physician, but I'm also a patient. Yes, you are, but you still come from a different mindset. You still don't see things the way our patient families see them. They bring a whole different perspective to it.
I don't think they have given us anything that the council as a whole have not felt they wanted to take the challenge on. The items that the council have worked on have had an impact on the guidelines and the policies that the hospital have implemented.
I do think having patients and families involved in improvement work is crucial. It's not just about patient satisfaction scores. It's really about moving the organization's level of professionalism up.
There are always questions that we as clinicians can't answer, things that affect our patient's experience. We're not the experts, but they are. We need to have the patient-family viewpoint at the center of all our decisions.
And it takes leadership from the board, but I think especially leadership from the executive suite.
anything you can do to increase performance is going to give you an edge. And I'm here to tell you, patients and family councils can help you do it. You're going to hear things from those members that you're just not going to hear anywhere else.
And your biggest fear, of course, is that you'll get people on there that really don't have anything but a bone to pick with the hospital.
We have to kind of dismantle that fear because, like a lot of fear, it's irrational. People actually sue less if you talk to them after that outcome. They don't sue more.
I think it's a little odd that people wait until they get beaten up in the press because the community hears about a bad event. We have 200 to 400,000 deaths occurring every year from preventable medical harm. If you think that they're occurring at 30% of the hospitals and the other 70% are totally air-free, you're kidding yourself.
As you share data and information, you get much richer conversations and discussions around what it means and what can be done about it. It's hard to imagine not having them involved. I just can't imagine that.
In fact, I think it would be a problem if you didn't have an advisory group because I think you're missing a big part of your community.
Major systems in this country are prioritizing it and putting resources into building PFACs. So if your hospital hasn't done it yet, you're behind.
Don't be skeptical, just you need to jump in and do this. It's really a great way to receive feedback in terms of the organization in an unbiased way.
I would say you have to try it. You will be amazed.
So I think, Marty, you want to try something new here? Maybe before we go to the next video, see if we have any questions. I see Janice has joined us.
Oh, hi, Janice.
Hi, Marty.
Welcome.
I was on a health leads call. I just want to say that I thought the discussion is wonderful, but like I was just on you probably know who health leads are, right? They work a lot in the social determinants of health and whatever.
Yep.
And they were just mentioning, that when they watch something or when they hear from people and they're, people all white, right, on the call or that they, in a leadership team, that they sometimes these individuals who are sharing from all over the United States, right, like Brooklyn and California, were sharing that they felt like the leadership had bought in, but in reality, they hadn't. After all these community meetings, that it turned out that wasn't what their bottom line was. So it's very important what you brought up here. And I look forward to hopefully seeing more diversity, but that's a very excellent video, in my opinion.
Thank you, Janice. We took our time. We did build diversity in this, and we want to do even more than that. So, in fact, I think we should show you our next video, which is, yeah.
But this shows that just because people are white doesn't mean that they're not buying in, right? I mean, this is
right. Yeah. And
Janice,
yeah, go ahead, Marty.
Well, one of the things I just want to say, yes, because you're hitting a nerve with me, is so much of healthcare leadership is still white.
Yeah.
And frankly, and so
majority.
Yeah, I mean, we've done our best to bring diversity into this, but when you're talking to leadership, you just have to kind of work around that challenge. So Armando, I'll set this up by just saying one of the big tasks in building a PFAC is organization and having someone who really is a project manager. And I think we've seen hospitals fail when they don't have somebody really moving, keeping track of deadlines and assignments and tasks. And the platform would help people do that, but you also just need a person. So we've tried to emphasize that as one of our big lessons learned.
Yeah. So this next video is actually identifying admin support, and it features our wonderful friend Christina Nicholson from University of New Mexico.
Hello and welcome. My name is Armando Nahum. I'm a patient safety advocate and a principal at H2Pi, the Healthcare and Patient Partnership Institute. Joining me today is Christina Nicholson from the University of New Mexico Hospital. Hi, Christina. Thank you so much for being with us today. If you don't mind, would you be so kind to introduce yourself and tell us what your role is at UNMH?
Hi, Armando. My name is Christina Nicholson, and I'm an office supervisor here at the University of New Mexico Hospital. My role on the PFACQS steering committee was a project support manager.
Christina, you have been part of a team engaged on building a PFACQS, Patient and Family Advisory Committee, as we call it at UNMH. And that has been for the last almost 9 months or so. And you have been so dedicated to the project. Can you please tell us why it is so important to have a person assigned to manage administrative support for the project?
Well, the reason it's so important to have a dedicated person to starting up a PFAC is there's so many moving parts. In every industry, like in healthcare, everybody has competing priorities. And without having a dedicated person to steer the ship, there are so many things that could fall through the cracks. So it's critical to have a key person to help steer this, this effort.
Thank you, Christina. You have also implemented a planning document with steps and goals and metrics of success. Can you briefly tell us about that?
Absolutely. Our consultants, H2Pi, provided us with documents to help us move forward with the PFAC effort. And with that, I was able to modify one of the documents to help us track our progress throughout the time that we had here at UNM Hospital. We were given a tight deadline, and those documents were critical in helping us track our efforts. So the modifications that I made helped me to track the assignees, the timelines that we had, the necessary meetings that we needed to have, who I needed to touch base with and pull into the projects at what time. It was critical. Without having those documentations that H2Pi provided us, and without creating that spreadsheet to help keep us on track, I think we would not have met our deadline.
Thank you so much, Christina. It's always a pleasure talking to you.
Thank you, Armando. It was a great pleasure working with you and your team.
So, well, Marty and I keep talking about these 3 activities: learn, do, and inspire. So we've just showed you what the type of learn activity is all about. I think now we'll take you to a do activity, which is Marty mentioned it briefly earlier. Again, each activity has its own objective. And this particular one, the do activity, we ask to complete a PFAC assessment tool that we provide over here for them to download. And then we give them the 4 steps instruction: download and review it, complete it, organize a meeting with your project team to discuss your completed assessment tool, and then save it to your computer. And then we ask them to upload it on this button right here, add content. They can upload their document so that Marty and I can review it for feedback. And then we ask them to reflect and answer on 3 questions here. What did you learn from the activity? What opportunities should we recommend to leadership? And then what did you find most exciting from completing the assessment? This is a way for Marty and I to constantly and continuously learn from each organization as well. So it's obviously a learning tool for us just as much as it is to them. So Marty, do you want to say anything here?
Well, the assessment tool is basically meant to be a baseline for them to, see where they are, for us to understand that, and then to measure their own progress. So we ask, pretty much we have like 12 buckets, I think, Armando, of hospital operations, but do you have patient family advisors involved in your HR decisions, in your rounding, in your educational activities, just to kind of plant the seeds that these are, once you build this resource, these are the ways you can use it. And it becomes part of our measurement as well. Yeah. So that's the tool, and I think you covered the feedback well.
Yeah, and we even, yeah, go ahead, Marty.
I think I'm just looking at time, and I do have this root canal starting in 8 minutes. So should we skip the next one and just do the one with Colonel Coffee?
Sure.
Okay.
Let's go back over here. So Marty had briefly mentioned it earlier that when we build PFACQS, we always encourage, obviously the PFAC, the organization has its own priorities, so they tend to bring these priorities to the PFAC to help them out. But we also encourage the PFAC itself to bring their own priorities to the organization. And so we like that bilateral, partnership, working together. And in this particular video, we want to show you a member of the MedStar Georgetown University Hospital, who's been a PFAC member there since the beginning. And he talks about council priorities for your PFAC.
Hello and welcome. My name is Armando Nahum. I'm a patient safety advocate and a principal at H2Pi, the Healthcare and Patient Partnership Institute. Joining me today is Lieutenant Colonel Stephen Coffey. Hi, Stephen. If you don't mind, would you be so kind to introduce yourself and your role at MedStar Georgetown University Hospital Patient and Family Advisory Council for Quality and Safety?
Hi, thanks Armando. I am, as you said, Lieutenant Colonel Stephen Coffey. I'm an Air Force officer, a patient advocate, and member of the MedStar Georgetown PFAC for Quality and Safety. So I've been there since 2014.
Thank you, Stephen. When a hospital or healthcare system has an active PFAC, we see them engaging the PFAC in projects that are strategic priorities. The MedStar Health Sepsis Prevention Initiative that you contributed to is a good example of that. What about the other way around? Projects that the council sees as important and brings to the organization? Have you seen this happen?
Absolutely. One of the things that drove me to become a member of MedStar PFAC was the fact that my son, Stephen, who had a liver transplant at a very tender age of 8 weeks old. He had a transplant due to a metabolic condition called galactosemia. And this condition doesn't allow his body to break down the simple sugar, the lactose that's found in human and animal milk. So when we were in the hospital, immediately following his transplant, one of his providers said that he needed to have his soy milk calorically dense. And so what that meant was to add some powdered soy milk to his formula so he could gain more weight while in the hospital. And I thought it was just as simple as being able to run down to the big grocery store to pick up a can of soy milk and bring it back to the hospital. But I was told that I couldn't do that, that thing had to be sent through materials. It had to get through billing. It had to be through management. And it was on a weekend, of course, when all the things that fall apart in the hospital, they always happen on the weekend. And so I realized then that there was a gap in care. And so when we started our PFAC in 2014, one of the first projects we worked on, and we brought this to MedStar Georgetown as an organization, was to look at our dietary. How can we fix that gap that's seen in care where we can provide nutrition to patients? So when you think about how it is that patients are oftentimes able, and the PFACs are oftentimes able to bring issues to the hospital, it's something that requires a listening to our voice. And one of the things we've worked on at MedStar Georgetown's PFAC is opioids. I mean, that's an issue that some of our community members who've been impacted by family members and friends that have had opioid concerns and issues, we brought that to the PFAC and said, hey, this is something we need to look at, maybe medication reconciliation, and brought it to our PFAC for MedStar Georgetown to take a look at. The other things, and this is something that's very near and dear to my heart as a minority, I think the world and certainly our country had an awakening with George Floyd, what that happened this summer. And our PFAC saw that we needed to look at diversity and inclusion. We need to look at some of these unconscious biases that occur. And so we brought that issue of looking at diversity and inclusion to our PFAC to have that as an issue that we raised amongst the hospital. And what was really great about this is that they've taken that and said, you know what, it may not be a physical medical issue or concern, but it is certainly a concern that we need to address and to talk about because it impacts physical medicine, how we deliver care to our patient population. And so one of the things we've done at MedStar Georgetown was to start these hot topics, if you will. And we've recently had one where we talk about diversity and inclusion. We look at the COVID crisis that's going on now. This pandemic has a severe impact in mental health. And another one of those topics that we brought to our PFAC, to our leadership, to say, hey, we need to look at how mental health is impacted because of COVID, not only from the patient perspective, but also from a provider perspective. So I think when organizations and hospitals partner with their PFACs and really value their voice, big changes can happen.
That's absolutely excellent, Stephen. I really enjoyed talking to you today, and I can't thank you enough for giving us your time. We know how busy you are. So thank you so much for all of that. We really appreciate it.
So I really appreciate this opportunity to speak with you guys, and wish you the best.
Okay, I'm going to take one quick minute. We talked about the third activity, which is Inspire, and what does it look like? Basically, Inspire, as Marty mentioned, is to for you to not only give us feedback, but also to inspire others from your learnings. So you can share a story right here. You can upload any kind of document you wish, a PDF, a Word document, and even a video. And then you can share the story. You can share with everyone, a particular group, or individuals. So this is really a wonderful way for disseminate all of the good work that you might be doing. So with that, I do want to have a few minutes for Q&A. But remember, I mentioned to you about these tabs right here. What do? So the quest is actually, Rally calls it a quest. We tend to call it a journey, PFAC journey, but it's this entire program is a quest. The network is actually showing you who the people are that are taking this program with you. Discussion is anything that you can message one another. You can message us as well. Have a private discussion or a team discussion. The leaderboard basically shows you who is in the entire project. And this is a point accumulating system that we've built, which kind of inspires everyone to sort of compete. And it's really wonderful. We find it to be very helpful. The resources is where we put all of our video and presentations. Right now, you only see 4 in here, but it's the live version. It's full of videos and PowerPoint presentations. And then the dashboard actually shows you the entire progress, the progress as a group, or you can search individual, and shows you in a graphical way, where you're at that particular time. So I'm going to open it up now for Q&A, unless Marty, you want to mention something else.
Well, we designed this for a project team that's going to build a PFAC, and we also are curious about whether it'll be used by collaboratives. If there were, say, a hospital association that wanted to pull together 10 hospitals to build PFACs, and if you use it that way, each hospital could keep its data private and share what they want.
Yeah.
So I just put that out there. Yeah.
Yeah. I also mentioned to you at the very beginning that for those of you that are already embarked on this journey, or you already have a PFAC, Marty and I are working right now to build the assets for what's learned. We gave a bonus right here, which is a journey to PFAC 2.0. And that's where we take the current existing PFACs into the next level. So let's have some question and answers. I'm going to stop sharing this. There we go. I know, Kathy, I know you have some questions, so fire away.
Feedback. Kathy, you're muted.
You're mute.
Okay, so I was saying it's interesting you're bringing this to us today, because we just were talking this week about how can we help some of our hospitals reestablish after COVID, get this up and running. And I mean, I like what I see, and already, Armando, I had you down to contact anyway, just to see if there would be any way to work with you as we're trying to get this started again. So definitely I like what I see, and would love to have more information.
Yeah, and what we can do is, if you like, we can talk offline a little bit more, and maybe show you a little more in details. you know, when we have more than 1 hour at our disposal. So we'll talk offline on that.
Yeah.
But thank you. Thank you very much.
Yeah, because actually we've got we're trying to help some of our small rural hospitals also start a PFAC. And actually we had some of the PFAC folks from Emory come and do a talk for us for about an hour, and they were just outstanding. And we've talked to some of the WellStar folks, and we're trying to get them also involved with us. So yeah, great work being done out there.
Yeah, we've had, this is our third demo, and our second demo, we had the PFE lead from Emory see this platform. So yeah, yeah, they're great. Anybody else? Janice, I know you have questions.
I don't really have questions, but I was just trying to say it's funny that this is today because anyway, we've just built out a national website for Kaiser. And, you know, when you're dealing with a large organization like Kaiser, it took a long time. It took us years actually to put this together, but now we're meeting monthly, and we have they've brought all of the nationwide, all of the advisors are on a platform, and there's opportunities, you know, it's a one-stop shop for you know, onboarding and all that. But I think, you know, maybe some of the members would even be, you know, Jonathan Bullock. I don't know if you know him. You might know him, Martin. Do you know him? Jonathan Bullock is the head of, he might just, you know, be interested in looking at it, but I don't know, because you're doing a lot. It's a lot more what you're doing. It's about training and bringing people on, but I really appreciate the videos and whatever. So today I actually recorded a video for the platform where they're pulling together to be able to show, like 17 of us advisors are just make a couple sentence comment. And so really the website has only been live for a few months. I haven't even really browsed it much, but a lot of it is closed and only open to the partners. So I guess my question is on yours, it's interesting you developed this out. I can really see that this could go, you know, with other organizations, and they could pick out what modules if they didn't want all the modules. But do you have a way for them to stay in contact afterwards, like an alumni or something like that? We have found in the past that has worked, where people are able to communicate with each other, and or they could use a platform called like PFCC Partners or IPFCC Connect. And because sometimes that's something that's really important to other advisors and for people that are seeking advisors also. Thank you.
Yeah.
Armando, Dennis, thank you. I have to run because I'm gonna.
I know.
I'm in for a root canal right now.
I'm sorry, you're having a root.
But Armando, you'll cover our business model, right, with them as we wrap up.
Yep, I will.
Okay. Bye, everybody.
So good luck, Marty.
Bye, Marty.
Bye.
Yeah, good luck, Marty. So what Marty was referring to, well, first of all, I want to address something with you, Janice. In the chat here, I see something you mentioned about sepsis. We have a fantastic video that I was not able to show you, obviously, for lack of time, on sepsis. And it's called The Tale of Two Sons. Lieutenant Stephen Coffey, who son experienced sepsis, who survived, who survived sepsis, and then my son who had sepsis and did not survive.
Oh, wow.
And it's
I'm so sorry to hear, but it's so important because I actually had something called occult sepsis, and I ended up in the hospital 5-6 days with it. So even though all my labs didn't necessarily indicate I was in organ failure, I mean, I was going near that.
Yeah.
So I'm sorry to hear about your son, but I'm glad that you're able to share the story with other people.
Yeah, thank you very much. And that's what gets me going every single morning. Kathy knows that about me. I have to do something so Josh didn't die for nothing. And anyways, so Marty wanted me to cover our last point here, which is our business model. Why have we done this? Number one is to help organizations out there who, well, because of COVID And what COVID has taught us, which is we probably are never going to go to 15 conferences a year anymore. We're probably just going to do like maybe 2 in person. The rest of them are going to be virtual because organizations are finding out that it's cheaper. You can attract many more people. People can sit in the comfort of their own home office and attend virtually. It's not the same as that networking one-on-one, you know, I agree, but organizations are starting to move in that direction. And that is one of the reasons why we built this platform. We wanted to give the, when we go back to whatever the normal is again, we wanted to give that flexibility to organization to say, hey, you can bring us in person. We'd love to come to your hospital, but like what UNMH did, you know, they couldn't bring us in person. This is a perfect platform. You can learn in here. You can interact with us at any given time. If there's a question on Tuesday morning, Marty and I will get a notification through our devices, whether it's our desktop, our phone, our tablet. Immediately we get notified that you want to talk to us. And so we immediately get on the platform and have a video conference. It's really an unbelievable platform. And so what we want to offer to all the people that we know in our network is that we'd like, as a business model, we like to offer a 10% finder's fee for bringing any client to us. But it's not just a monetary thing. We could also give that 10% to an organization of your choice, a charity of your choice, whoever that may be, just so that someone would benefit for that. Certainly Marty and I didn't get into this to become rich by any stretch of the imagination. It's not something that that we chose to do, you know, advocacy to get rich and famous. But we want to contribute as well. So if we get a client, we want to give back. And so anyone that you can think of that may want to take this platform or go on the next journey. They already have a PFAC, they want to take PFAC 2.0. Certainly we can help them with that and go from there. I'll stop here. I know we passed the time. I can't thank you enough for staying on longer than we asked you to. But if there are any last minute questions, then we'll just adjourn. Anything else?
I found your video online.
Oh, you did? Yeah, it's on YouTube.
On MedStar, Georgetown University. I think it on Facebook or something. Yeah.
Yeah, it's if you go to YouTube, it's there. Yeah.
Right. Thank you.
Yeah, thank you.
Well, good luck. I think this is great.
Well, thank you very much, Janice. Appreciate it.
I think community health centers could possibly use it. I mean, that's
well, yeah, it's funny you say that because Marty and I are working very hard to try to promote this to also LTCs, right? Long-term care facility, which nursing homes, they are in so much need of that partnership. It just doesn't exist. And we just want to say, look, you can do this. And some nursing homes that claim they have a PFAC, and we checked them out, they have these crazy rule that when the resident passes, the family members that belong to the PFAC no longer can belong. They are booted out automatically. And it doesn't make sense. It's so sad because they already have that experience going through it with their loved one, right? And their facility. So it just doesn't make sense.
They can mentor the new people.
Of course. At the very least, use them as ad hoc members. But they have this rule. It's like, well, you know, your mom passed away, you're out. It just doesn't, you know.
Wow, that's sad.
I just want to say, I am so happy to hear that you have a PFAC 2.0, because oftentimes when you develop a PFAC, sometimes it gets stagnated. And I think it's really nice so you can push that reset button and make sure that that you haven't lost your commitment or lost the reason why you came together in the first place. So I'm really happy to hear about the 2.0, and I'm looking forward to hearing more about that.
Yeah, and obviously we can work, together on that. I think you were helped originally in building your PFAC from Natasha, right? Natasha was the consultant on boots on the ground, so to speak.
Yes, Natasha Washington, yes.
Yeah, but obviously I know your CEO very well, So we can work together, and you'd be surprised. This 2.0 is just mind-boggling. It just takes you to a whole new level. It's all of the learnings that we discover across the country. We put them all together into one platform to share with all of you. So it's really, really great. Georgetown University Hospital has just last week started their 2.0 journey. So yeah, don't hesitate to reach out. We'll send you all kinds of documents.
Thank you.
My pleasure. Well, thank you again for your time. And please, if you need to reach out to me or Marty, please do so. I'm sure you have our email address. Again, I can't thank you enough for giving us your time. So any further question, please email us, let us know. And Kathy, we'll talk offline. We'll set up time.
Absolutely. Thank you so much. This was great today. Thank you.
Thank you. My pleasure. Have a
Thank
good
you.
day. Yeah. Bye-bye. Bye.